Over 40 million Americans live in a pharmacy desert. For these populations, the independent pharmacy is the sole clinical lifeline, yet the infrastructure supporting these hubs is rapidly fracturing. Independent pharmacies provide specialized services like multi-dose packaging and personalized coaching that increase medication adherence rates by 3.0 to 7.2. As the last mile of healthcare infrastructure erodes, mortality rates in rural and low-income communities rise. Pharmacy benefit managers, or PBMs, are the architects of this market failure. These entities have transitioned from simple administrative processors into dominant corporate gatekeepers. Market concentration is extreme. The big three PBMs, CVS Caremark, Express Scripts, and Optum Rx, manage 80%. PBM dominance represents an intentionally engineered oligopoly designed to extract maximum profit by eliminating unaffiliated competitors. Mapping the financial mechanics of a single pharmacy transaction reveals how PBMs extract capital from independent providers. The primary mechanism is the direct and indirect remuneration, or DIR fee. Originally part of Medicare Part D, these were repurposed by PBMs as retroactive clawbacks. In this model, a pharmacy dispenses a drug today, but the PBM assesses a punitive fee weeks or months later. This makes profit margins entirely unpredictable. Data shows retroactive DIR fees increased by 107,400% between 2010 and 2020. These delayed fees also harm patients. Because the negotiated price at the counter excludes these trailing clawbacks, patient coinsurance is calculated on an artificially inflated gross price. Instead, PBMs replaced transparent administrative fees with an opaque risk matrix that broke the independent pharmacy business model. On January 1, 2024, a CMS rule change eliminated retroactive DIR fees to increase price transparency. The rule required all pharmacy price concessions to be reflected upfront. On the balance sheet, this immediately lowered the visible reimbursement amount at the point of sale. While well-intentioned, the timing of this transition created a liquidity gap known as the DIR hangover. Pharmacies faced a simultaneous obligation. They had to accept lower upfront reimbursements for 2024 while still paying off the trailing DIR fees from the end of 2023. This double payment period proved fatal for many small businesses, with owners reporting sudden cash flow debts exceeding $100,000. This regulatory-induced liquidity drain triggered the wave of over 2,000 closures seen in early 2024. PBMs extract further margins through spread pricing, a practice involving the hidden difference between what a health plan pays and what a pharmacy receives. In this mechanism, a PBM charges a health plan a high price, reimburses the pharmacy less, and pockets the difference. To maintain margins, PBMs use generic effective rates, or GER, to claw back payments across entire drug categories. These rates are often set at levels that force independent operators to dispense common medications at a financial loss. A new structural threat arrives in 2026, the implementation of the Inflation Reduction Act's Maximum Fair Price, or MFP. Pharmacies must dispense negotiated drugs to seniors at the lower MFP, but they face significant administrative delays in being reimbursed for the difference. 3 Access Advisors forecasts that this payment settlement delay will cause an $11,000 weekly cash flow loss for the average independent pharmacy. Without federal cash flow protections, the IRA's reimbursement mechanism will trigger a secondary wave of closures, removing the local providers seniors rely on for these negotiated drugs. As federal action stalled, states began developing aggressive legal models to protect their pharmacy infrastructure. The legal foundation for this shift was the 2020 Supreme Court decision in Rutledge v. PCMA. The Rutledge ruling clarified that states have the authority to enact cost regulations that protect pharmacies from below-cost reimbursements. Kentucky emerged as a national model by enacting Senate Bill 50 to reform its Medicaid program. The state eliminated spread pricing and opaque rebating by transitioning to a single state-administered PBM. This transition resulted in an 8.6% reduction in per-member costs, saving the state an estimated $172.5 million in 2021 alone. These state interventions prove that reimbursement floors and single PBM models protect both taxpayers and healthcare providers. While state reforms provide a defensive shield, addressing the underlying market structure requires federal antitrust enforcement. PBMs are accused of violating Section 2 of the Sherman Act by monopolizing specialty drug markets and steering patients away from lower-cost generics. The FTC has filed suit against the Big Three for using unfair methods of competition to artificially inflate the price of insulin. Strategic imperatives include codifying federal reimbursement floors, mandating pass-through pricing, and resolving the 2026 IRA cash flow gap. Structural separation, forcing corporations to divest either their PBM arms or their retail pharmacy assets, remains the ultimate antitrust solution. The survival of the independent pharmacy is essential to a resilient, equitable public health infrastructure. These providers offer the clinical advocacy that no automated mail order system can replace.